This morning, we're going to talk about acute diabetic emergencies. So the content of the lecture today, we're going to go over a few endocrine emergencies, including diabetic ketoacidosis, a specific entity called euglycemic ketoacidosis, hyperosmolar hyperglycemic state, metformin-associated lactic acidosis, and half of the lecture will be talking about hypoglycemia in diabetic and non-diabetic patients. So we'll have some cases to illustrate throughout the lecture as well. So the first thing we're going to go into is diabetic ketoacidosis and euglycemic DKA. So first is talking about the pathogenesis of DKA. So actually, how does this DKA arise? So it usually occurs in people with a relatively significant or absolute insulin deficiency, for example, in type 1 diabetes. And it's always have a trigger. And when you have a trigger and you have a insulin deficiency, then of course your glucose in your blood starts to rise. And when your glucose rises, then your plasma osmolarity also rises. And when your osmolarity rises, then you drive an osmotic diuresis. So the urine tries to excrete more glucose, and at the same time, it also brings out potassium as well and fluid as well, and therefore you have a volume depletion. And so this is about the part of kind of dehydration and hypokalemia. So on the right side is how you drive the ketones and the acidosis. So when you have insulin deficiency, the body also breaks down your adipose tissue. It increases your free fatty acids, and then it increases the formation of ketones. And therefore, a result of this would be ketosis, acidosis, dehydration, and then we call diabetic ketoacidosis. So I think you might have heard of the different ketones in your body, including acetoacetate, beta-hydroxybutyrate, and also acetone. And we'll also mention about this later on. So there's always a precipitating factor. So there are 6 I's here. It's just a general illustration. And for patients with severe or absolute insulin deficiency, they're prone to DKA because they rely on exogenous insulin. So for example, type 1 diabetes, especially those newly diagnosed, or inadequate insulin doses, or some patients withheld their insulin for some reasons. Iatrogenic causes like drugs, including steroids, which you all know can cause hyperglycemia, and some antipsychotic agents is also prone to cause diabetes. All sorts of infections, because that drives a acute response in your body and acute stress reaction. And also inflammation, ischemia like myocardial infarction, stroke, bowel ischemia, etc., and some intoxications like alcohol. So what is the criteria for diagnosis of DKA? So to put it very simple, you just separate out the D, the K, and the A. So D, we're talking about diabetes, so we're talking about the glucose level. So the cutoff varies slightly among different guidelines of different countries, but generally either glucose more than 14 or more than 16.7. K, we're talking about ketones. So at least the patients would have a moderate to severe ketonemia and ketonuria. And A means the acid base, the acidosis. So the pH would be less than 7.3 and the bicarbonate less than 15. But when we test the ketones, especially in the urine, we need to pay precaution because we just mentioned we have different ketones in our body, including acetone acetate, beta-hydroxybutyrate acid, and also acetone. So in generally, ketones usually appear in the urine before a significant increase in blood ketones. And that's why we always ask patients, especially those with type 1 diabetes, when they're ill, when they're feeling unwell, check your urine ketones because it might be the first sign of developing DKA. However, when you have a severe acidosis, especially those that eventually needs hospitalization, acetoacetate will be converted to free beta-hydroxybutyrate acid. And therefore, in hospital setting, we always check this beta-hydroxybutyrate acid. But however, if you check urine multistics in the hospital, you need to pay precaution because urine multistics rely on a reaction called nitroprusside reaction. It detects only acetoacetate, but not beta hydroxybutyric acid, and therefore it might be misleading. And therefore, for those who actually need hospitalization, we usually check the plasma, BHBA, or sometimes we call BOHB. So what is the goal of management for DKA? So I'll separate into 5 goals. The first goal is rehydration, because you know those with DKA will be dehydrated due to the osmotic diuresis. The second one is insulin, because they usually have a severe insulin deficiency or absolute insulin deficiency. So it's crucial to give them insulin, clear up the ketones, normalize the glucose and the osmolarity. The third goal is to maintain and correct any electrolyte and acid-base imbalance. The fourth goal, of course, to identify the cause and treat the underlying cause. And 5 is to avoid complications from treatment. So in general, the protocol would be just like many other diseases. You start off with initial assessment, medical history, physical examination to identify any obvious precipitating cause. The most important, you start off with hydration. So in the first 1 to 2 hours, we can give a more aggressive fluid rehydration. And then what we just mentioned, intravenous fluids for rehydration, insulin, correct electrolyte and acid-base disturbance. So this is actually from the Houseman Handbook, so a general guide on how to manage DKA. So what do we need to monitor and what do we need to check? So of course, to establish a diagnosis of DKA, you need to check the glucose from the blood and the urine. You need to check the ketones also from plasma plus or minus the urine. You need to check the blood gas to quantify, to look at the acidosis. And of course, you need to check on the other electrolytes and correct for any imbalance. And as for identifying the underlying cause, we commonly perform X-rays, ECGs, septic workup, etc. So for monitoring, we need to keep a close eye on the glucose level, including the blood and the urine. We need to keep a close eye on the electrolytes and also the blood gas. And of course, other general parameters we need to monitor, including our vital signs, conscious level, urine output, etc. So the first goal we talked about was rehydration. So in a patient with diabetic ketoacidosis, they can have an average fluid deficit of up to 4 to 6 liters. So in the first 2 hours, we could go more aggressively and then gradually replace in the coming hours or 1 to 2 days. So in elderly patients or patients with cardiac problems or heart failure, sometimes we might consider a CVP monitoring just to make sure we wouldn't overhydrate the patient, causing fluid overload or heart failure. So if we have a electrolyte imbalance with a high sodium level, we might consider using half-half solution or dextrose solution instead of NS. And also, if the blood glucose starts to drop and improve to less than 14, we would also change our IV fluids with some dextrose inside so that we could keep on our insulin infusion until the ketones are cleared. So how do we give insulin? We give an insulin infusion intravenously. And how do we mix up the insulin infusion? Most commonly, most hospitals use 50 units of atropine in 49.5 ml of gelfusin. Of course, some centers uses NS as the fluid as well. So we then give the insulin infusion as intravenous, and we try to maintain the heme sticks or the glucose between a range of around 6 to 11 or kind of closely to normal. So when the patient's ketones has been cleared, the acid base has been corrected, they're fully conscious and they're eating, then we could switch the intravenous infusion back to subcutaneous insulin. And in later slides, I'll talk about how you can switch from IV to subcutaneous. So roughly, how do we calculate the dose? And we also highlight that we would suggest an overlap of the insulin infusion and the first dose of subcutaneous insulin for at least 2 hours before you stop the insulin infusion. So how do you actually give the insulin infusion? What rate, what dose are we giving? So usually there are two methods of giving. You can actually give as a fixed rate, around 0.1 unit per kg per hour. So roughly if someone weighs around 50 kilograms, we could give 5 units of intravenous insulin infusion per hour. Or you can give it as a scale. And mostly in a general ward setting, we would use a scale because it's more easy for our nursing colleagues to titrate accordingly. So for a scale, you basically refer to the latest glucose value or the Hem6 value, and then you adjust the amount of insulin, the unit of insulin you're giving per hour in the next hour. The aim of giving intravenous insulin is, of course, to control the glucose and the ketones, but we don't want the glucose to be dropping too fast because a rapid change in osmolarity can sometimes cause cerebral edema, although it's quite rare. So the aim of decreasing the plasma glucose is by 3 to 4 millimoles per hour. And therefore, when the glucose reaches less than 14, we just mentioned, we might change the intravenous fluids to add some dextrose inside so that we can keep on the insulin infusion until the ketones are cleared. So the third goal we mentioned is electrolyte replacement. And in the setting of DKA, most of the patients are in an absolute deficient of potassium because of the osmotic diuresis bringing out the potassium and also intracellular shift. So there is a risk of hypokalemia, especially when we start to correct the DKA. And that's because when you have DKA, you have acidosis, you know about the intracellular shift. So when you have acidosis, already the body cells are moving the potassium into the intracellular, extracellular department. And when you also know that when you give insulin, it actually shifts the potassium back into the cells. So when you correct the acidosis and you're giving insulin, there's a risk of further hypokalemia. And therefore, before we start intravenous insulin infusion, it's always urgent to get your renal function and know the potassium level with the frequent and regular monitoring of the potassium level during the treatment. And of course, to replace the potassium as needed and ensure to avoid severe hypokalemia. And as for acid base, sodium bicarbonate is very rarely required and should be only given in the ICU setting. The reason for that is the acidosis is mostly due to the ketones. So once you start the treatment with insulin infusion, with IV fluids to suppress the ketones, the acid base usually corrects rather rapidly itself. So it's only when you have a very severe acidosis that renders the patient to be life-threatening at any time, then we might give a bit of sodium bicarbonate infusion. But if the pH is more than 7, we don't usually recommend any sodium bicarbonate treatment. So we also want to avoid the complications from DKA and also the complications from the treatment. So when a patient has DKA, they're usually dehydrated, so they might have hypotension. They may be so acidotic that they may be in a comatose state, cerebral edema, hypothermia. And when you're dehydrated and you're immobilized, you have an increased risk of thromboembolism. So we also need to pay attention and correct these complications as needed. And we also need to watch out for complications from our treatment. That includes fluid overload, especially in elderlies, in people with heart conditions. We need to pay attention to avoid overcorrection of the dehydration. Insulin infusion itself, if it's too aggressive, it might cause hypoglycemia. And we just mentioned as well, when you correct the acidosis or when you're giving intravenous insulin infusion, it causes a shift of potassium into the cells and can cause hypokalemia. So a case to illustrate, we have a 19-year-old lady. She lives with her family and she has a sister. She's a pharmacy student. So unfortunately, she was diagnosed with type 1 diabetes around 4 to 5 years ago when she was age 17. And you know that in type 1 diabetes, you usually present with acute onset of DKA requiring admission to ICU. And from then on, she was started on multiple daily injections of insulin. However, all along she had a poor compliance to treatment and diet. And she had repeated admissions of DKA because she stopped her insulin herself. So she had 4 DKAs in 2019 and 5 DKAs in 2020, at least 5. And her A1C was poorly controlled in the range of around 10 to 16%. So the first time I saw this lady, because previously she was managed by pediatrics, and so the first time I saw her was in September in 2020. That was a 6th admission for DKA. And the most common presenting features of DKA includes epigastric pain, nausea, repeated vomiting, and a feeling malaise and tired. And so her blood gas and her other blood parameters confirms a DKA, including a blood gas of pH 7.15, which is less than the 7.3 we just mentioned. The bicarbonate is less than 15. She has a high beta hydroxybutyric acid, a glucose of 24, and a large amount of ketones in the urine. So standard treatment, she was admitted to ICU and given intravenous fluids and insulin infusion, and then recovered. So what's the reason for her to have a poorly controlled type 1 diabetes? And that's because she's still very young. She's only around the age of probably nowadays just in the early 20s. So it was very difficult for her to accept the diagnosis of type 1 DM, which occurred just very rapidly. And then from then on, she requires lifelong multiple daily injections, which means 4 injections of insulin a day. So she does not wish her peers to know that she has diabetes. And therefore, this time when she had a 6th admission for DK in 2020, she actually went camping with her friends. And because she doesn't want her friends to know that she had diabetes, she deliberately did not inject her insulin in front of her friends. And then she was found comatose by her friends in the camp. But however, she's still young. She's still playing along with her life. So I actually met this lady again at her 7th admission for DKA in 2020. And that was on the last few days of December. And again admitted for DKA. And when she was discharged, just discharged from ICU, it was the 31st of December, which was the last day of 2020. And the only thing she asked us was whether she could discharge straight away so that she could count down with her friends. So I think for a young lady, it really takes some time for her to accept her diagnosis because she doesn't know about how severe the diabetic complications can be in the future. And it's still the age that people want to go out and play, meet with friends, eat, and just enjoy life. So for her, we just have to keep her in, and hopefully one day she will start to accept the diagnosis, and hopefully the diabetes will start to improve. So the second case is a 76-year-old lady, and she has been having type 2 diabetes for around 20 years. She's on metformin, alogliptin, which is a DPP-4 inhibitor, and diamicron, which is a sulfonylurea. And as many other elderlies, she also has other medical problems, including hyperlipidemia, ischemic heart disease, COPD, and open cholecystectomy. Her A1C is actually pretty good controlled. It's 6.9%, and her renal function is normal. So in 2018, she was admitted to another hospital for atypical chest pain, infective COAD exacerbation, and acute retention of urine. So we all know that when patients have acute exacerbation of COPD, we commonly prescribe steroids. And therefore, she was given steroids and she has steroid-induced hyperglycemia. And for some reason, the doctor at that time added another oral hypoglycemic agent called the empagliflozin, which is an SGLT2 inhibitor for the patient, and commented that the patient was reluctant for insulin. However, do take note that her A1C actually was pretty well controlled, and it was only a transient steroid-induced hyperglycemia for the COAD exacerbation. So once you stop the steroids, the glucose actually would improve itself. And therefore, she was discharged with another SGLT2 inhibitor added, And then 2 weeks later, she came into hospital. She came to us for generalized malaise, poor intake, suspected tarry stool, which eventually was not any GI bleed, and the hypokalemia. So on admission, you could see her random glucose is 15. It's not very high, although it's more than 14, but it's not those very high levels we might see. Her blood gas shows significant acidosis, a pH 7.12 by carb 7, beta hydroxybutyric acid 6.1, which is high, and a large amount of urine ketones, and also hypokalemia and a mild acute kidney injury. So she was again admitted to ICU, put on intravenous fluids and insulin infusion, and stabilized and changed to subcutaneous insulin later on. There is another similar case. It's a 64-year-old lady, some family history of diabetes, and she also had type 2 diabetes diagnosed in 2008. At that time, presented with weight loss and osmotic symptoms for around a month, and her A1C on presentation was 12.3%. However, she's actually quite lean. And over all these years, she had a suboptimal control on 3 oral hypoglycemic agents, so eventually added insulin in 2009, and that was just 1 year after she was diagnosed with diabetes. And the glucose remained suboptimally controlled, and she was changing multiple daily injections since 2012. So actually, she has been on 4 injections of insulin per day since 2012. It's near 10 years till now. So she did not have any history of diabetic ketoacidosis, no microvascular complications so far. A1C, not perfect, but it's reasonably controlled around 79%. And her latest drug regimen was Janumet, which is a combination of metformin and DPP-4 inhibitor, Lantus, a long-acting insulin, and Humalog, which is a rapid-acting insulin covering her 3 meals per day. So what happened to her was she was frustrated that she was on 4 insulin injections a day for so many years. So she went to visit a private nephrologist and not an endocrinologist around 1 to 2 months before she was admitted to us, as she was very keen to reduce her insulin injection frequency. The reason she found a nephrologist was that actually her tanga was seeing this private nephrologist also with diabetes, and she has been managed very well, and therefore she visited this private nephrologist as well. So in the first visit that the private nephrologist saw her, he added her on Amaryl, which is an SU, empagliflozin, which is an SGLT2 inhibitor, and stopped her 3 injections of Humalog for her meals. So subsequently, she recorded her glucose control. The fasting was actually pretty nice, but you can see the pre-dinner glucose level is already on the rising trend. So she attended follow-up with the private nephrologist, and the follow-up was just 3 days before she was admitted to us. And the private nephrologist thought that her glucose was pretty well controlled with these drug titration, and therefore he advised her that she could try stopping her Lantus as well. And at the same time, he also advised her to reduce her carb intake given that she has diabetes. So then she has stopped all her insulin, including Humalog and Lantus. So just after she stopped her Lantus, she started to develop dizziness, generalized weakness, vomiting right afterwards. She does not have any obvious infective symptoms. And then she started to be so weak that she fell at home, landed on her occiput with a stark hematoma, and eventually brought to hospital. So when she arrived to the A&E, they found that her glucose level was 13.2, which is not very high, but she is in a very, very severe ketoacidotic state. So pH was 7.0, bicarb only 4, and a very high plasma ketone level. So again, admitted to ICU, given fluids and insulin infusion. So what is the second and third case we're trying to illustrate? There's an entity you might hear nowadays called SGLT2 inhibitor-related euglycemic DKA. So again, there's usually some triggering factors, just like those DKA we mentioned. People might have intercurrent illnesses and infection. They might have reduced fluid and food and fluid intake, especially reduced carb intake. Reduce insulin doses. It might be iatrogenic. It might be because of a doctor's advice. intoxications, for example, alcohol. So presentation of euglycemic DKA basically is much more or less similar to usual DKA's: malaise, nausea and vomiting, abdominal epigastric pain, shortness of breath or confusion related to the severe acidosis. So the plasma glucose level is commonly less than 14 to less than 16. So we mentioned that usual DKA will be more than 14 or more than 16 or something. The name for euglycemic DKA is basically telling you that the glucose level is usually not that high. Treatment is actually similar to usual DKA. Of course, you stop the SGLT2 inhibitor, you give fluids and insulin infusion. So how does people actually trigger DKA from SGLT2 inhibitors? Actually, when you start SGLT2 inhibitors for your patients, SGLT2 inhibitor itself already increases a certain degree of lipolysis, breakdown of the adipose tissues, and increase in free fatty acids. So SGLT2 itself can already increase your ketones in your body, but it's usually of a mild degree. But sometimes when some people are very sensitive to SGLT2, or they're not a good candidate for SGLT2, or they have other precipitating factors like infections, then they would usually start to have a poor intake. They reduce their carbs, and some people reduce their insulin as well as a result. But when you start to reduce your insulin and you reduce your carb, then your body breaks down more fatty acids, more adipose tissue. It breaks down more fat to provide new energy. So then your ketones level increases even more. And then when your ketones increase even more, you start to feel nauseated because of the ketones, and then you eat even less. And then you have volume depletion. You have, you thought you're eating less, so some people reduce their insulin further, and then this vicious cycle eventually drives into euglycemic DKA. So it's always important that you select the right patient for SGLT2 inhibitor. And I think you all know that SGLT2 inhibitor nowadays is like a miracle drug. So it's actually very good for type 2 diabetes, especially those obese, type 2 diabetes, and metabolic syndrome. You know that SGLT2 nowadays is even being approved for non-diabetic patients as a heart failure drug, or even as a renal protective drug with those with proteinuria CKD. So SGLT2 is actually a good drug, I have to agree, but you always have to be careful with selecting the appropriate patient. So for those with diabetes, we would avoid starting SGLT2 inhibitor in those with type 1 diabetes because they have absolute or severe insulin deficiency. They're prone to DKA already. And also for those with type 2 diabetes who are also ketosis prone, for example, those with a very long duration of type 2 diabetes. And also avoiding patients prone to recurrent infections or dehydration because this is a triggering factor for the vicious cycle of euglycemic DKA. And if you're starting a patient with SGLT2 inhibitor, you also need to avoid any concurrent very low carb diet or ketogenic diet. And also remind the patients withhold SGLT2 inhibitor and maintain adequate hydration during intercurrent illnesses or infections. So this is another interesting lady that came in with euglycemic DKA. So she's 42-year-old. She has type 2 diabetes since 2014, previously on metformin, already up to the maximum dose of 1 gram BD. She has no diabetic complications. And she went for a body check because she wanted to have receive a COVID vaccine, and then found out that her glucose is actually very poorly controlled with an A1C of 10.5%. And therefore, the GP started her on SGLT2 inhibitor in August last year. And apart from that, she has asthma, obesity, ovarian cysts, thalassemia trait, etc. So actually, this lady is young. She has type 2 diabetes. She's obese. She looks like a metabolic syndrome lady. I would say it would have been a very, very good drug for her in terms of SGLT2 inhibitor. So adding SGLT2 inhibitor for me is actually a correct choice. But what happened afterwards was she developed reduced appetite, severe heartburn, nausea, recurrent vomiting, and worsening of osmotic symptoms, and 17 pounds of weight loss since she started SGLT2 inhibitor in just 2 weeks. So 2 weeks, 70 pounds sounds great. So that's a reason. She delayed seeking medical attention because her heartburn kind of mildly improved with Nexium. She noted a remarkable weight loss, which she thought was happy, and she noted that her glucose was actually coming down. But eventually, she became so weak that she had to take leave from her work, and she said she couldn't even get out of bed. So eventually, she called the ambulance and was brought to AED. So on presentation, her glucose was 10.6. She was in severe acidosis, a pH 7.24, bicarb of 11, high plasma, and urine ketones. And what happened again was euglycemic DKA, so we stopped the drug and we gave her insulin infusion, intravenous fluids, and then she recovered. But then you would ask, she seems to be a lady that is a good, that is appropriate to start SGLT2, then why did she develop euglycemic DKA? The reason was that at the same time she started her SGLT2 inhibitor, the patient was advised by her private GP to take no carb diet given that she has diabetes. So I don't know whether the patient actually misunderstood what the GP said, or did the GP really said that? Because when you don't take any carbs, it's something like a ketogenic diet. Your body breaks down adipose tissue, increases free fatty acids, and actually further increases your ketones. So it's important to remind these patients you need to take appropriate amount of carbs. And she actually lives in Sai Kung, and therefore she said over the 2 weeks that she was started on SGLT2 inhibitor, she basically kept eating seafood because she lives in Sai Kung. Okay, so the next entity of diabetic emergencies we're going to talk about is hyperosmolar hypoglycemic state or hyperosmolar non-ketotic state. So it's basically talking about the same thing. So we'll start off with a case illustration. A 77-year-old gentleman, non-smoker, social drinker, living alone, ADL independent. So he's been having type 2 diabetes for quite some years. He had a history of stroke, but with a very good recovery. So what happened was that the son used to call the patient regularly for a chat or make sure he's okay. And then the son just suddenly one day realized the patient is not returning his phone calls. And therefore the son went to his home and found the patient lying on the floor, drowsy with confused speech. He cannot recognize the son and he has urinary incontinence. So although this lecture today is diabetic emergencies, but when you admit a patient with confusion, you always need to rule out all sorts of causes. So of course that includes metabolic causes, for example, glucose problems, sodium problems, calcium problems, vitamin, hypothyroidism, adrenal insufficiency, organ failures like liver and renal failure, alcohol or alcohol withdrawal. And of course, all sorts of infections can cause confusion, especially in elderly, and the neurological disorders like stroke, bleeds, malignancy, etc. And of course, drug causes where the list can be exhaustive. So when we see an elderly with confusion, of course, we need to do some baseline blood tests, look at any organ failures like liver renal function, look at any electrolyte imbalance, thyroid status, glucose, blood gas, and we search for any infections like septic workup or urine multi-6, etc. Chest X-rays, ECGs, and of course, a CT brain. So these are the results of this elderly. So he had acute kidney injury with a creatinine of 230, hypernatremia, and severe hyperkalemia. His calcium was also high, but likely as a result of dehydration. And his glucose level was 46 with a very high osmolarity. On the other hand, the blood gas is not in a severe acidotic state, so the pH is more than 7.3, and the bicarb is more than 15. Thyroid function is normal. He has a very elevated white cell. So eventually, his septic workup found that his blood and urine culture had E. coli, so he actually had E. coli urosepsis, which caused the confusion and caused the HHS state. So HHS, or another name is HONC, it occurs more frequently in older people with neglected type 2 diabetes or with a precipitating acute illness. And as compared to DKA, it develops over a longer period. So for DKA, they can present within days, but for HHS, they can present up to 1 to 2 weeks. So the pathophysiology of HHS sounds similar to DKA, but it's actually slightly different. So in those with HHS, the insulin deficiency is present, but it's usually less severe as compared to DKA. So these patients have relative insulin deficiency instead of an absolute or severe insulin deficiency. So, but at the same time, when you have insulin deficiency, then your glucose starts to rise. And the rise in glucose will drive the osmotic diuresis, and we also mentioned that in DKA. And when elderlies have inadequate fluid replacement as a result, then they have a profound intravascular volume depletion. So this is another slide trying to tell you how different DKA and HHS is. So there are some pathophysiology that actually overlaps between the two. But you can see that in DKA is usually a more absolute insulin deficiency. Therefore, you have a more severe degree in terms of ketones and acidosis. Whereas in HHS, it's usually a relative insulin deficiency, and therefore they usually present with a more severe degree of dehydration due to the high glucose and the osmotic diuresis. So for the diagnosis of HONC or HHS, basically we break down the name again into H, NK, and HO. So the first H is talking about glucose level again. So these patients usually have a more severe degree of hyperglycemia, and it's usually more than 33 millimoles per liter. NK means non-ketotic, so which means we're talking about the ketones. And our plasma and urine ketones is usually either absence of ketosis or just a mild degree of ketosis. So the arterial pH we will expect to be more than 7.3 and the bicarb more than 15. And it should have only a mild degree of ketonuria or ketonemia. So HO is the osmolarity. So because of the high glucose, their osmolarity in the serum is usually more than 300 or more than 330 milliosmol per kilogram, depend on different guidelines. And a highlight of HHS or HONC is that these patients usually have a very severe degree of dehydration and also impaired sensorium. So just like DKA, there are usually factors that precipitate HHS, and that includes some therapeutic agents like drugs, some procedures, or acute or chronic illnesses. So in terms of therapeutic agents, the most common that we know of is steroids. We know steroid causes hyperglycemia, and some antipsychotics or anti-epileptics can also cause hyperglycemia. In terms of procedures, therapeutic procedures, for example, dialysis, because, for example, in peritoneal dialysis, the dialysate actually contains glucose, which can be absorbed into the body. Hyperalimentation means aggressive nutritional replacement. For example, for some patients with gut problems in the hospital, we might be prescribing a high nutritional supplement, which might actually cause hyperglycemia. And all sorts of surgery, because it actually causes acute stress, and our stress response in the body would also bring up the glucose. So any source of chronic illnesses can put the patient at risk of developing HHS, especially when they have acute illnesses on top. For example, any source of sepsis, burns, trauma, GI hemorrhage, cerebrovascular events or ischemic events, inflammatory events, etc. So the general protocol for management of HHS, it looks quite similar to DKA. It's all about initial assessment, medical history, physical exam. Again, we start off with aggressive intravenous fluid replacement, especially in the first 1 to 2 hours, and then followed by insulin infusion, correction of electrolyte disturbance. But bear in mind that in HHS, we usually do not need to deal with acid base. So as compared to DKA, those with HHS usually have a more severe fluid deficit, which can be up to 6 to 10 liters of fluid deprivation. And therefore, the fluid replacement needs to be regressive. But if you have a rising sodium or high sodium, then again, you can change to half-half solution to avoid further hyponatremia. As for insulin infusion, the need of insulin doses is usually lower than that required in DKA. And therefore, if we're giving a patient a insulin infusion by the sliding scale that we saw for DKA, the dose of insulin we usually cut it by half in HHS. And we also need to avoid rapid correction of glucose, just like in DKA, because if your osmolarity drops too fast, it can precipitate cerebral edema. So we mentioned about when the patient is stabilized, how we're going to switch the insulin infusion intravenously to subcutaneous insulin. So how do we actually calculate the dose and estimate the dose? So remember, you have to wait until the patient's ketosis has resolved or the HHS has resolved, the patient is metabolically stable and tolerating diet before you actually switch to subcutaneous insulin. And how do we estimate? You can actually calculate the daily insulin requirement from the hourly infusion rate while the patient was on intravenous insulin. And then when we want to switch to subcutaneous insulin, we would take 30% off from the intravenous insulin infusion requirement. I'll illustrate that in the next slide with this example. So when you switch to subcutaneous insulin, you know that there are kind of different insulin regimens that we can give or different insulins to choose from. So we can choose either intermediate acting insulin or a basal bolus regimen or what we call MDI. But remember that you should overlap the intravenous insulin infusion and the first dose of subcutaneous injection for at least 2 to 3 hours before you stop the pump, which means you stop the intravenous insulin. Because subcutaneous injection takes a little time to take action. So for example, if you inject a Lantus, which is a long-acting insulin, it takes up to 1 to 2 hours before it takes effect. So don't stop the intravenous infusion straight away. You need to wait for 2 to 3 hours after you gave the first dose of subcutaneous insulin before you stop the intravenous one. So I'll give a little example on how you calculate the insulin requirement. So for example, we had the patient with DKA. The patient was put on intravenous insulin infusion. And then over the last 24 hours, we added up all the insulin that the patient required, and it's 45 units on intravenous insulin. So when we want to switch to subcutaneous, we take 30% off. So 45 times 70% is around 36 units. So the subcutaneous daily requirement of insulin we estimate is 36 units. Of course, this is just a general estimation. Later on, we have to titrate the subcutaneous insulin according to the glucose profile of the patient. So how do we give this 36 units? We can either give it by intermediate acting insulin 2 injections a day. So we usually give 2/3 in the morning to cover the daytime glucose and 1/3 at night to cover the nighttime glucose. So 36 units, 2/3 in the morning is 24 units of protophane in the morning. And 1/3 at night, so it's 12 units, that should be PM. So 24 units in the morning and 12 units at night. And remember to stop the intravenous insulin infusion 2 hours after you give the first dose of subcutaneous insulin. But apart from intermediate acting insulin, we can actually give basal bolus regimen, which means MDI, which means a long-acting basal insulin, and then rapid-acting insulin for each meal. So for type 1 diabetes, they usually require MDI because they're totally insulin deficient and they rely on exogenous insulin. So how do we switch to MDI? So take the same example. The patient requires a total of 36 units per day. And if we want to switch to MDI, we usually give half the dose as a long-acting basal. So half is around 18 units. For example, Lantus, 18 units at bedtime. And then we give the remaining half split into the 3 meals. So the remaining 18 units was split into 6 units of rapid-acting insulin, for example, Humalog per meal. So half as basal, the remaining split into 3 meals as rapid-acting insulin. So a few slides on the table to actually summarize the difference between DKA and HHS. So it's kind of a wrap up of what we just talked about. So in DKA, the onset of the development of DKA usually occurs more rapidly. It can be even within a day or within just 1 to 2 days. But HHS can present in a prolonged period. So both have an inadequate amount of insulin, but in DKA, it's more severe or more absolute insulin deficiency. Both usually have triggering factors like infections or infarctions or drug causes. But of course, HHS usually occurs more in elderly, so you have more infarctions and more chronic diseases. So how do they present? DKA usually presents more with shortness of breath, abdominal pain, nausea, and vomiting. And this is largely driven by the ketones and the severe acid-base imbalance. Whereas HHS presents more weight loss, osmotic symptoms, thirstiness, because they have a more severe degree of dehydration. The same for physical findings. In HHS, you have more severe dehydration, therefore you have more clinical signs of dehydration like dry mucous membrane, which is skin turgor, and dehydration, etc. And whereas DKA, you have more severe acidosis, so you see more of a cosmal breathing patterns. In terms of diagnostic criteria, as a summary, as compared with HHS and DKA, HHS has a higher presenting glucose level, higher osmolarity, less ketones as compared to DKA, a relatively normal or just slightly reduced bicarb as compared to DKA, and a less acid-base disturbance. So that actually wraps up on DKA and HHS, and we'll move on to one more topic before we have a short break. So this is another case of 45-year-old gentleman living alone, unemployed. He has been having type 2 diabetes with retinopathy since 2013, and lately he has been on metformin and a Mextart, which is a premixed insulin, 14 units in the morning and 8 units at bedtime. So he also has some other medical conditions, including dyslipidemia, ventricular septal defect, depression and psychosis on antipsychotics, gallstones, CBD stones, a little bit of anemia. His A1C was actually very well controlled, or I would actually say a little bit too over-aggressively controlled since 2016. His renal function is normal. So he was admitted to AED for hypoglycemia, and he was noted to have dizziness after missing his lunch, and noted hemostasis to be 2.3 in the ambulance. Initially, he was just admitted to the observation ward in AED because for hypoglycemia, it can be well managed in AED and directly discharged. However, he was noted to be tachypnic and tachycardic with palpitation, which is unusual, and therefore he was eventually admitted to medical ward. And at the same time, he was complaining of nausea, shortness of breath, and palpitation, and again found to have sinus tachycardia. He was initially treated as a heart failure and given aspirin and Lasix in view of the symptoms. However, when we saw this gentleman, he actually did not have obvious signs and symptoms of heart failure. His X-ray is not congested. ECG shows sinus tachycardia. In terms of blood tests, hemoglobin is more or less similar to baseline. No signs of active infection. He had a mild degree of acute kidney injury, and there was no significant rise in the troponin T level. He was admitted for hypoglycemia, and therefore the random glucose was still a little bit low. However, what alarmed us was his blood gas. His pH of 7.41, which is normal, but his bicarbonate and the basic says actually showed that he's in a certain significant degree of acidosis. And it was a high anion gap condition, and eventually he was found to have a high lactate level. So all the other toxicology screen is otherwise unremarkable, and these are mostly just his usual drug and the Lasix we gave on admission for presumed heart failure. So this was his blood gas over the next few days. You could see that he had a severe degree of acidosis on the 9th of October. His pH remained normal because he was heavily compensating by breathing very rapidly. And he eventually had acute kidney injury with his creatinine peaking around 260. And also high lactic level on admission. And therefore, we stopped his metformin. We presume it's a metformin-related lactic acidosis. And we maintained appropriate ABC treatment. And eventually, the lactate came down and the renal function improved. So this case is trying to illustrate what we call MALA, metformin-associated lactic acidosis. Of course, there are usually triggering factors as well. For example, renal or liver insufficiency, heart failure, acute infections, intoxication with alcohol, any sorts of decreased tissue perfusion or hemodynamic instability or hypoxic states. So when the patient is in a severe acute condition, we would usually temporarily withhold metformin. So the presenting symptoms is actually, again, quite similar to DKA because it's the degree of acidosis that causes the symptoms, including nausea and vomiting, diarrhea, altered mental status, and shortness of breath. Diagnostic evaluation, of course, we need to take note of the hemostasis just to make sure it's actually not a DKA. ECGs to look for any underlying causes, electrolytes, blood gas, and of course, a lactate. But we have to pay attention that we need to rule out other causes of lactic acidosis, for example, severe sepsis, bowel ischemia. Treatment basically stop the metformin, ABC. Again, similar to DKA, we don't usually give sodium bicarbonate unless the patient has a severe degree of acidosis. And in severe cases that it's not improving with these above treatment, some patients may need hemodialysis. Okay, so I would take a short break, maybe for 5 minutes, and then we can come back at 10:05 to talk about hypoglycemia. Okay, so in the next hour, we're going to talk about hypoglycemia. So we'll separate the talk into hypoglycemia in diabetics and hypoglycemia in non-diabetics. So as a normal response, when our glucose starts to drop in our body to a degree of less than 4, our body will trigger, we call it the counter-regulatory response, and that includes an increase in glucagon, epinephrine, growth hormone, and also cortisol, which would try to increase the glucose level. But if this counter-regulatory response fails to bring up the glucose, then we'll start to develop hypoglycemic symptoms or even neurological dysfunction. So exactly what our body does is when we have hypoglycemia, it will send a signal to our brain, and then our brain and hypothalamus and brainstem will sense it, and then it will trigger a response to tell our autonomic nervous system to do something. So then it will tell our adrenal glands to increase the cortisol level and increase the epinephrine level. It will also tell our pancreas, it will tell our alpha cells to increase the glucagon production and tell our beta cells to reduce the insulin production. And all these triggers would have an effect on the muscle, fat, and liver to reduce the glucose utilization or to increase the glucose production from the liver, and that would try to bring up the glucose level in our body. And therefore, when we start to have hypoglycemia, the first symptoms that we usually have is over the left-hand side, we call the autonomic response, or kind of the sympathetic symptoms. And that includes sweating, tachycardia, palpitations, tremor, nervousness, etc. But if our glucose continues to fall, then we start to develop neuroglycopenic symptoms. That includes irritability, confusion, abnormal behaviors, or even seizures, loss of consciousness, etc. So we had patients with type 1 diabetes who's actually up and about and working. And he actually mentioned that once the colleagues found that he's starting to talk nonsense, then the colleagues would know that he's having a hypoglycemia, and then his colleagues would force him to eat. So we'll first talk about hypoglycemia in diabetics. And why is this a significant issue is that when we look at the most common drug causes causing hospitalization, insulin actually plays the second most major reason, and as well as oral hypoglycemic agents. There are various causes of hypoglycemia in the diabetic patients. It can be due to treatment related, for example, the use of insulin and sulfonylurea, because you know that these treatments have hypoglycemic risk. It might be because we're controlling the diabetes too tight. For example, if we bring someone's A1C down to 6 or even less than 6, we would expect the patient to have hypoglycemia. Maybe because of loss of the counter-regulatory mechanism, we call hypoglycemic unawareness. Some patients may have liver and renal impairment that actually affects the pharmacology of the drug treatment in your body. For example, in renal impairment, it might prolong the effect of sulfonylurea or insulin, etc. It may be because of alcohol, because alcohol can also cause hypoglycemia by reducing the hepatic glucose production. It might be because of a mismatch of meals and insulin. What we're talking about here is, for example, patients are expected to inject their insulin, the prandial insulin, before their meals or just before they start to eat. But sometimes patients forgot and they basically finished their meals before they recall that they haven't injected the insulin, and then they went to inject it. And therefore, there will be a mismatch and there will be a subsequent postprandial hypoglycemia. Exercising, like aerobic exercises, can of course bring down your glucose and cause hypoglycemia. So what we're trying to illustrate in this slide is that this is a very famous study in terms of diabetes, and everyone endocrinologist should know of. It's a DCCT trial. Basically, what this trial tries to illustrate is that if we treat a patient with type 1 diabetes intensively, very intensively, aiming for a very nice A1C level, it definitely reduces the risk of microvascular complications, including retinopathies, nephropathies, and neuropathies. And so this is basically just as expected results. But what this trial subsequently also showed that for those patients with intensive insulin treatment, the risk of having severe hypoglycemia is up to threefold as compared to we call conventional treatment. So for conventional treatment, the hypoglycemia risk is here. For those with intensive insulin treatment, the hypoglycemia risk is threefold above. So treating it intensively reduces microvascular complications, but definitely increases the risk of severe hypoglycemia. So we mentioned what is hypoglycemic unawareness. So basically it is defined as the onset of neuroglycopenic symptoms before the appearance of autonomic symptoms. So some patients, if they have recurrent hypoglycemia, they will start to lose their autonomic response. So they don't feel sweaty, they don't have tachycardia, palpitations. And as soon as they have hypoglycemia, they drop down. They have loss of consciousness, they're confused, or even they have seizures. And hypoglycemic unawareness occurs in approximately 40% of people with type 1 diabetes because they have the most brittle diabetes control. They are totally dependent on exogenous insulin. So they have easily have hypers and hypos, and with a less frequency in type 2 diabetes. So what are the possible etiologies of hypoglycemia unawareness? Why do people do not have autonomic symptoms and they go straight to neuroglycopenic symptoms? So if a patient has very frequent and recurrent hypoglycemia, their body will start to blunt the autonomic response. If a patient has antecedent hypoglycemia, which actually means the patient had a hypo event just recently, maybe like just a few hours ago, they had a hypoglycemia. If they had another hypoglycemia a few hours later, they usually have less symptoms. So for long duration of diabetes, especially type 1, they usually have a blunted response. Or if the diabetes control is too tight, or if you have patients with other conditions, for example, elderly, depression, alcoholism, etc., all these people have a blunted autonomic response. And some drugs, for example, beta blocker, because it actually suppresses your sympathetic system, so they also have a blunted response. So in elderly, we just mentioned they're at a risk of hypoglycemia unawareness because elderly usually have a lot of other comorbidities and medications to start off with. They have the defective counter-regulatory mechanisms, and therefore they have reduced hypoglycemic unawareness. Therefore, they do not feel having hypo symptoms until the glucose reaches at an even lower level. So what do we define hypoglycemia? We usually define the patient at least having a glucose as less than 3.9. Some people may be asymptomatic, that we just mentioned, but hypoglycemia is also very important because it's associated with increased cardiovascular risk and sudden death. So as much as we think that a good diabetes control is important, it's also important to avoid hypoglycemia because it's just as risky. And it may also contribute to cognitive impairment. And of course, common sense, the lower the A1C, the higher the hypo risk. But you still have to bear in mind that even with people with diabetes that is poorly controlled, it does not mean that they won't have hypoglycemia. They could still be at risk. So what is the risk of hypoglycemia in terms of your heart? So when you have hypoglycemia, it triggers a lot of pathways. It increases your body's inflammatory response. It causes endothelial dysfunction. It drives your sympathetic system, increases your adrenaline and your heart workload. And it also affects your blood coagulation abnormalities. And all these can drive a cardiovascular or thromboembolic risk. And this is a study from our team, from Professor Alice Korn and colleagues. And it also shows that those with diabetes, with chronic kidney disease and other comorbidities, if they have hypoglycemia, they have a much higher risk of a mortality risk. So basically, it shows that those with hypoglycemia and CKD, which is the dark purple line, they have the highest mortality, which is obviously more significant than all the other groups with hypoglycemia with or without CKD, or with no hypoglycemia and CKD at all. So when we have hypoglycemia, we first need to manage it rapidly. Of course, we check the airway, the breathing and circulation. We need to confirm that the patient really has hypoglycemia. So we either repeat the capillary blood glucose, or we send the blood for the laboratory measurement. But if you're going to send a blood for laboratory measurement, you know that you don't have the results immediately, so do not delay your treatment. So basically, how you correct the hypoglycemia, first, it depends on whether the patient is conscious. Second, of course, it depends on how severe the hypoglycemia is. So if the patient is not conscious, then of course you need to give the glucose replacement by intravenous or by non-oral routes. For example, intravenous bolus, followed by an infusion until the patient is out of hypoglycemia. So if the patient is conscious, you could give him some simple carbs like soft drinks, fruit juice, some sugar cubes or candies, followed by a small carb meal. But if you have a patient that is unconscious and you can't set up intravenous line, then you can give a intramuscular glucagon injection or oral glucose if you're able to protect the airway. So what exactly is 10 to 15 grams of simple carbs? So if you tell the patient eat 10 to 15 grams of simple carb, the patient basically does not know what you're talking about. So you need to quantify to the patient what is 10 to 15 grams. There are actually some standard glucose tablets or gel tubes in some pharmacies where you could buy, and it's obviously labeled how many grams there are. But if you're not taking these, you could actually go for half a cup of juice or regular soda. You could give 1 tablespoon of sugar, honey, or corn syrup, or a few candies or jelly beans. So I once had a patient who came for diabetes follow-up, and she was telling me how smart she's able to manage her diabetes. And she's telling me that she knows how to manage hypoglycemia. And then she told me she takes candies, but those candies are free of sugar. So it's sugar-free candies. And she told me she chose sugar-free candies for her hypoglycemic attacks because she knows she has diabetes and shouldn't take any carbs. So that actually shows that she's not well educated. And the reason that her hypoglycemia settles itself is because of the body's own counter-regulatory response. So education on hypoglycemic management is also very important in diabetes treatment. So when you've initially corrected the hypoglycemia, make sure that you monitor it closely over the next few hours until it's totally stabilized. How long you actually observe depends on what causes the hypoglycemia, what drug the patient has taken, and the liver and renal function. And of course, explore the reason for having the hypoglycemia and avoid that in the future. So nowadays, there are a lot of new things going on in the market that can actually help you to reduce the risk of having hypoglycemia in a diabetic patient. And I will talk about a few of these in subsequent slides. I think some of you might have heard of some newer blood glucose monitoring techniques called the continuous glucose monitoring or flash glucose monitoring. There are some other devices that can actually help, for example, type 1 diabetic patients to give insulin. So in old days, we have just multiple daily injections of insulin. But in these centuries, we have what we call insulin pump or continuous subcutaneous insulin infusion. Our drugs are always evolving and always improving. So nowadays, we have some newer insulin analogs which has a lower hypoglycemic risk. And we will also try to choose diabetic medications with low or no hypoglycemic risk. And we have to pay caution in the use of drugs that can increase the risk of hypoglycemic unawareness. For example, we mentioned beta blocker and some mood drugs. Individualized diabetic targets, for example, in elderly, we might not be aiming for very tight A1C control. So sometimes for elderlies, we might even aim up to around 8% as an optimal diabetes control. And again, importance in patient education and self-management in terms of hypoglycemic management, diet, exercise, and alcohol advice. So these are some of the newer glucose sensing technologies that we have nowadays. It's actually very commercially available nowadays. So it's not something that is very sophisticated. So in the old days, all we could do or all we know is doing finger pricks to self-monitor your glucose. But nowadays, there are a lot of sensors in the market. It's actually very easy to apply on your skin. And then you can remotely monitor your glucose every a few minutes with a reader or even with your smartphone. So this is one of the models that is very commonly used nowadays by many patients. It's called the flash glucose monitoring device. So it's very easy to apply. You just chop it on your skin and then it sticks there. And when you want to know your latest reading, you just scan it with a reader or with a smartphone. And then you have your reading on your reader or smartphone. And basically, it also shows a whole trend of your glucose throughout the day. So it can also help you to identify any hypoglycemia. And these newer technologies, apart from doing the sensing, it can also generate a lot of reports for our physicians to read and to find titrate the drug treatment or insulin. So for example, it can actually show you the percentage of time that this patient's glucose has been in target. So green is in target, of course, the yellows and the reds are out of target. It can give a summary, for example, over the last 1 to 3 months on the average general glucose pattern of the patient. It can also tell you the whole glucose profile throughout that day. And it also has trends in your phone, which tells you whether your glucose is now trending up or is it trending down. So we also mentioned that some technologies nowadays, you can give insulin by a subcutaneous infusion instead of regular injections. So we call these, generally we call them insulin pump, but basically it's a subcutaneous continuous infusion. So you have your pump here, you have some tubings, and then it's attached on your skin. There's a very short cannula under your skin subcutaneously, so the insulin goes in continuously instead of regular injections. If some patients have a sensor, this is one of the sensors. The sensor can communicate with the pump and actually tells the pump how many insulin to give over the next few minutes or few hours. So it can actually regulate your insulin infusion. So we also talked about some newer insulin nowadays. So I think you should be aware of different insulin that we have in terms of different action profiles. That includes rapid acting or short acting insulin for the meals like insulin lispro, aspart, glucosine, regular insulin like atropine or Humulin R. You have your intermediate acting insulin, we call the NPH insulin like Protophane or Humulin N. You have long-acting insulin like Glargine or Detamir, etc. And you also know that there are different ways of giving insulin. So some people might just need a basal insulin, so you can give a once daily basal or a twice daily intermediate basal. Some patients might also need prandial insulin if they have a significant postprandial rise. So you can actually give it with a premix insulin, which is more convenient, or a basal bolus therapy like 4 injections a day. So this slide and the next slide, basically, it's for you to read because we have these colorful cards nowadays, which summarizes all the different insulin action profiles, all the different insulins that we have, the action profile, the onset time, when does this insulin peak, and what is the duration. And so you can have a brief read at your own time. But nowadays, there are some newer insulin which is said to have an even lower hypoglycemic risk. So the two on top are the kind of slightly older insulin, for example, the intermediate MPH. You could see that's an obvious peak and trough for intermediate MPH insulin. So there might be a risk of hypoglycemia when it peaks. So insulin glargine has a less peak and trough, and it's more long acting. So it actually has a lower hypoglycemic risk. But when we go down to the bottom, we have some even newer insulin called the insulin glargine U300, which is a more concentrated glargine than the traditional U100 glargine. We also have another insulin from another company called insulin degludec. So insulin glargine U300 and insulin degludec are the latest types of insulin analog we call the ultra long acting insulin. So the good side of these ultra long acting insulin is that they don't really have a peak and trough. So it's kind of peakless, and it's more flat, it's more long acting, it's more smooth. And therefore the risk of hypoglycemia is even lower. We also mentioned about nowadays a lot of drugs that have a low or theoretically no hypoglycemic risk. So this is the ADA guideline, which is kind of like a teen shoe for diabetes management. So it updates itself nearly every year, and with the latest evidence and a summary on how you treat diabetes. So if you go to the top, the first line therapy for type 2 diabetes is always still metformin unless it's contraindicated or it's not fit. But then it also has a red column here, which actually tells you if some patients have a compelling need to minimize hypoglycemia, what drugs should you choose? So we know that DPP-4 inhibitor, GLP-1 receptor agonist, SGLT2 inhibitor, and TZD are actually hypoglycemic drugs, anti-hypoglycemic drugs that have low or theoretically no hypoglycemic risk. And therefore, these are good drugs to choose from to minimize hypoglycemia. And it's only when these drugs doesn't work, then you consider some newer generations of SU or some insulin that have a lower risk of hypoglycemia. So when we talk about what is a good diabetes control, in the old days, we always just talk about A1C. But you have to bear in mind that A1C is just a general kind of like an average glucose. So nowadays, a good diabetes control is not just looking about A1C. You also have to address whether the patient have frequent or recurrent hypoglycemia, and you try to minimize hypoglycemia. You try to hopefully aim that so the patient has a higher time in the target range and lower glycemic variability. So what is glycemic variability? So the name implies how variable are the patient's glucose profile throughout the day. So this is a slide showing 3 patients, patient A, B, and C. So patient A has a high fluctuating glucose throughout the day. So it's like a roller coaster. It goes very high and then it drops rapidly. So patient B also has some rise and fall, but it's obviously much lower than A. Patient C is rather variable. It can go rather low at some days, and then it could go rather high at other days. So if we're just talking about A1C, which is roughly like an average glucose, actually patient A, B, and C would have the same A1C. So it's kind of like simple mathematics. You could appreciate that the average is probably the same. But if you talk about who has the lowest glycemic variability, I think you'll all agree patient B actually has the lowest glycemic variability. It varies the least. So nowadays, we know that glycemic variability is also heavily associated with the risk of macro and microvascular complications, as well as the risk of hypoglycemia. So nowadays, many newer studies are focusing on glycemic variability rather than just A1C alone. So what about hypoglycemia in non-diabetics? This can be quite a difficult topic. So do we go investigating into anyone that have a lowish glucose or kind of self-reported symptoms that's suspicious of hypoglycemia? And the answer is no. So when you want to start investigating a patient, make sure the patient at least fulfills a Whipple's triad. So the Whipple's triad consists of first, the patient has symptoms known or likely to be caused by hypoglycemia. Second is that during the patient having symptoms of hypoglycemia, there is a documentation of a low blood plasma glucose concentration, and not just a capillary finger prick. Three is that when the low glucose level is corrected, there is a relief of symptoms as reported from the patient. So the causes of hypoglycemia can be very long and very extensive. So on the right side is some drugs that is reported to cause hypoglycemia, but bear in mind that those with low or very low quality of evidence, I don't think you need to know of because they're not very heavily reported or justified. And those with moderate quality of evidence, actually these drugs are kind of less commonly used as well. So we focus on the left side, medical conditions that causes hypoglycemia. Of course, that includes drugs like insulin, sulfonylureas, alcohol, any sort of critical illness like severe liver renal failure, heart failure can cause critical illness hypoglycemia or severe sepsis. Endocrine causes like some other hormone deficiencies, adrenal insufficiency, glucagon insufficiency, etc. Non-islet cell tumor is a specific entity. I will talk about that later with a case illustration. And of course, some issues with insulin, for example, insulinomas, gastric bypass, autoimmune hypoglycemia, etc. So how do you approach a patient with a suspected hypoglycemia? I think the first thing, of course, is to know whether the patient has diabetes. If the patient has diabetes, then of course you go to look for whether the patient's on insulin or SU, and you adjust the treatment. If the patient has no diabetes, I think the first thing is to look at how ill they look like. If the patient is very ill, the causes are usually over the side, organ failure, severe sepsis, hormone deficiencies, etc. But if the patient looks apparently healthy, basically just walking around and just telling you that sometimes he feels a little bit hypo, then you look at the fasting glucose level, whether the patient fulfills the Whipple's triad, and you can also check the C-peptide, antibodies, etc. And there will be another slide later on summarizing the different causes and the different biochemical or laboratory findings that we'll see. So how do you work out for hypoglycemia? If the patient fulfills Whipple triad, and if we're able to catch a glucose low enough to be less than 3, and the patient is not a diabetic, we screen for hormone deficiencies, most important, adrenal insufficiency. We screen the insulin and the proinsulin and C-peptide in the body. So proinsulin and C-peptide is able to reflect your endogenous insulin secretion. So if you have a certain degree of endogenous insulin infusion, you will have a detectable or high C-peptide and proinsulin. Of course, make sure it's nothing factitious. And so you check the urine toxicology, especially to look for sulfonylurea levels. So for non-islet cell tumor hypoglycemia, which I'll talk about later, checking the plasma ketone with the VOHB, IGF-1 or IGF-2 would be helpful. But if we have a patient that we cannot catch a spontaneous hypoglycemia low enough to screen these, we would sometimes do overnight fasting or even extended fasting to catch the hypoglycemia up to 48 to 72 hours. But of course, this needs a careful supervision in the hospital to avoid a severe symptomatic hypoglycemic attack. So this table actually summarizes, I think, the kind of more common hypoglycemic causes that you need to know of and how are the laboratory findings. So drug causes like exogenous insulin, of course, you will have a high insulin level because our insulin level in our lab cannot actually differentiate endogenous and exogenous insulin. So it would be high. But when we have exogenous insulin injected, our endogenous insulin is expected to be suppressed. And therefore, our proinsulin and C-peptide would be detected to be low. And of course, these other parameters are normal because it's not actually related. So same, slightly different for OHA, sulfonylurea. Sulfonylurea actually increases your endogenous pancreatic insulin production, and therefore insulin would be high. Proinsulin and C-peptide would both be high because our endogenous insulin was increased. These other parameters would be normal, and a toxicology screen might be able to screen positive for sulfonylurea. As for insulinoma, it's again something endogenous, a tumor in your body that is excreting excessive insulin. So high insulin level, high proinsulin C-peptide level, and these other parameters would be normal. So the last one is IGF mediated. Autoimmune, I might not talk about too much. It's actually rather rare. IGF-1 mediated, it's a kind of tumor-mediated hypoglycemia, which is not insulinoma. So it's an IGF mediated, so our endogenous insulin would actually be suppressed. So insulin, proinsulin, C-peptide level would be either low or low normal, but the IGF-2 or IGF-2 to IGF-1 ratio would be high. I'll talk about that later on. So again, a few cases to illustrate how do we work up for hypoglycemia. The first case is a 23-year-old lady, good past health. She was presented with a minor head injury following an episode of loss of consciousness. And retrospectively, she recalled having 1 year history of recurrent episodes of LOC. Again, just because this is a diabetes lecture, so don't always just think about glucose causes. You should also go back to history to illustrate what is the timing of LOC, the duration of LOC, other associated symptoms, any preceding warning features, involuntary movements, how did the patient recover, any kind of post-event drowsiness, precipitating relieving factors, and any witness for the event. So bear in mind there is another exhaustive list of causes for LOC, which includes various causes of syncope, autonomic dysfunctions, cardiovascular diseases, neurological diseases, metabolic or electrolyte disturbances, and psychogenic factors, as well as drugs. So for this lady, her vital signs were more or less okay, just a little bit borderline tachycardic. She was sweaty on approach, no focal neurology, and eventually the capillary blood glucose showed hypoglycemia down to 1.8. So after giving intravenous glucose, she regained her consciousness. So basically, she fulfills the Whipple triad, and she also had a random glucose, which was 3.0. This was already after she was just given the intravenous glucose. So she has symptoms of hypoglycemia. She has a documented low plasma glucose, and her symptoms resolve after glucose replacement, and therefore she fulfills Whipple's triad. Other renal function electrolytes seems unremarkable. Urine ketones were absent. So again, we just talked about if the glucose is low, we can screen for all these things to try to find out the underlying cause. So eventually, we had a supervised fasting for this lady. And just after 8 hours of fasting, we were able to catch a glucose of 1.8. And we checked the insulin and C-peptide as well. And this insulin and C-peptide level was elevated. So she does not have adrenal insufficiency. We checked her cortisol. It is basically more than adequate. And urine toxicology was negative for sulfonylurea. So if we go back to this level, this table, this lady has high insulin, high C-peptide, negative OHA screen. So this only leaves basically two possible diagnoses: insulinoma, post-gastric bypass, or insulin autoimmune syndrome. And we just mentioned this is relatively rare, and the lady obviously had not had a history of post-gastric bypass, and therefore insulinoma is top on a differential that we need to rule out. So insulinomas are difficult to localize because some tumors can be rather large, but some tumors can be as small as a few millimeters. So there are various imaging techniques we could try to identify the tumor. That includes ultrasound, endoscopic ultrasound, CT, MRI, ultrasound scan, pancreatic arteriography, or even percutaneous transhepatic portovenous sampling, which is a more invasive method. So eventually this lady had a CT and they were able to find a lesion at the pancreatic tail. And so the most definitive treatment is, of course, surgical resection. But before we pursue resection, we need to give her something to at least reduce her hypoglycemia. So it can be due to dietary modifications, like taking in more glucose, some drugs like diazoxide, which can try to suppress the insulin secretion from your pancreas, but there are side effects of hirsutism, fluid retention, etc., and octreotide treatment. So this is another gentleman, 42-year-old, and he was presented in 1993 with 1-year history of inappropriate behavior. He had intermittent episodes of hand washing, so he keeps washing his hands. And sometimes he just suddenly became blank and not responsive and just staring for 1 to 2 minutes. He had some neurological investigations done and basically commented him to have complex partial seizures. And so he was started on anti-epileptic drugs and then became seizure-free for 3 years and then tried to tail off the carbamazepine. However, 2 years afterwards, he started to have recurrent episodes. And these episodes are more frequent. It can last up to 15 minutes. It occurs most commonly in the morning after a prolonged fasting. He was resumed on carbamazepine with a dose increase, but still having persistent attacks. And eventually, once when he was attending the clinic follow-up, he was noted to be confused at that spot. So they checked a capillary blood glucose for him and found that he was hypoglycemic. And therefore, they admitted him for investigation, and they found that the blood glucose was low down to 1.9, but the insulin level is abnormally high. So a preliminary diagnosis of insulinoma was again made. Unfortunately, he also had a CT done and also found to have a large pancreatic tail tumor. However, you can see on the CT was that he already had very extensive liver metastasis by the time he presented. So for insulinoma, the presentation can be rather variable. So the mean duration of symptoms before you present or before you diagnose is roughly around 28 months. So some people can linger on for a very long time before they present or before being diagnosed. Metastatic insulinomas usually present quite late into the course of disease, and up to 20% of insulinomas have been misdiagnosed with psychiatric or neurological disorders. So this is another lady, which is a very sad story we saw just around 2 to 3 years ago. 27-year-old lady. So she presented with some non-specific epigastric abdominal bloating since August 2018. So initially she took some Chinese medicine. But then she noted progressive abdominal distension and weight loss since April in 2019. And 1 month later, she was brought to AED because of recurrent symptoms that is suspected to be hypoglycemia, with sweating, palpitation, tremor, hunger, and dizziness. And she was found to be drowsy by her boyfriend and then found to have a very low, undetectable heme6 in the ambulance. And of course, after giving dextrose infusion, her mental state improved. So Whipple's trial is fulfilled. So upon admission to ward, she was found to be hypertensive, tachycardic, sweating and anxious looking. She's very cachexic. We don't actually know why she didn't seek medical attention over the last couple of months. And her abdomen was grossly distended. In terms of some baseline blood tests, there doesn't seem to be anything that it's very alarming. She just had a little bit of mild anemia, a little bit of raised liver enzymes, and a bit of sinus tachycardia. But because of the grossly distended abdomen, she was arranged in ultrasound. And ultrasound of the right lobe of liver found a very huge mass of 12 centimeters, and also another huge mass in the left side of the abdomen. And the radiologist can't really see what the origin of this very large mass was. And it was up to 18 centimeter in size. So you can actually imagine how distended her abdomen has been. So she went on to have a CT. And the CT commented radiological findings of lung metastasis, a 19 centimeter. They initially thought it was a left renal mass. Multiple lesions in the liver, the largest one measuring up to 14 centimeter, and suspicion of recent hemorrhage from either of these lesions into the peritoneal cavity. You can see on the CT a very large left-sided abdominal mass. You can't really see where the origin is. A very large liver mass as a metastasis. Eventually, she opted transfer to private hospital for further management. And so the private doctor arranged an ultrasound-guided biopsy of the mass. And surprisingly, the histology showed adrenal cortical carcinoma. So she was also found to have recurrent hypoglycemia even when she was on a dextrose D10 infusion. And also poorly controlled blood pressure, added on some antihypertensives. Eventually, because of financial reasons, the patient decided to transfer back to our hospital for further management. And even when she's on the D20 every 8 hours, she's still having refractory hypoglycemia. And therefore, we did an extensive investigation to work out for the cause of hypoglycemia. So we're able to catch that when her random glucose was as low as 2.5, she had a suppressed insulin level, which means that it's unlikely related to insulin problems like insulinoma, etc. Her beta hydroxybutyric acid, which is a plasma ketone, is also suppressed. So what does this signify? It signifies that although you don't have detectable insulin in your body, there seems to be some insulin-like activity in your body, because if you have insulin or insulin-like activity, it will suppress your ketones. No adrenal insufficiency because 2 cortisol levels were adequate. The IGF-1 is actually suppressed. In our hospital, unfortunately, we don't have a reliable assay to measure IGF-2. So when we don't have IGF-2, we could use IGF-1 as indirect evidence, because in non-islet cell tumor hypoglycemia, this would be suppressed. And urine toxicology does not show any suspicious sulfonylureas. So putting all these levels together, this lady's condition matches this condition we call IGF-mediated disease, or another term is non-islet cell tumor hypoglycemia. So low insulin levels, she actually had low C-peptide levels as well. I think I didn't put it here. Low IGF-1 levels. So before we go on to talk about non-islet cell tumor, just to highlight the progress of this lady, she had refractory hypoglycemia, so we started her on steroids, which is a treatment for non-islet cell tumor hypoglycemia, but and also some cornstarch, which is a kind of glucose that can slow down the digestion and increase the glucose level in your body. But it just partially worked in this lady. Some antihypertensive to control her blood pressure. In terms of oncological treatment, because of the extensive metastasis and she's so emaciated, she was deemed ultra high risk of operation and not a surgical candidate. So she was started on mitotane and chemotherapy, but shortly after her second course of chemotherapy, she succumbed due to chest infection at the age of 27. So this term it sounds difficult to remember or difficult to comprehend. So we call NICTH. So it means a tumor that is non-islet cell which means it's not insulinoma. It has a paraneoplastic syndrome that causes hypoglycemia. So the most common tumor type is epithelial origin, for example, most common HCC or mesenchymal tumors. So these are the tumors that has been reported to have an association with NICTH. So mesenchymal tumors are those kind of like soft tissue tumors. Epithelial tumors are those kind of solid organ tumors, and most commonly HCC. Adrenal tumors has been reported very rarely as well. So actually in our body, our regulation of our glucose or insulin action is a balance between insulin, IGF-1, and IGF-2 because they all have some insulin-like activity as an agonist or as an antagonist. So what happens when a patient has NICTH, which is a paraneoplastic condition from some tumors? So when you have NICTH, the tumor actually produces, we call something called the big IGF-2. And the reason for big IGF-2 is that the cleavage of this IGF-2 is slowed down, and therefore there are some accumulation of these big IGF-2 molecules. So this big IGF-2 actually causes a suppression in the pancreatic insulin production. But at the same time, it stimulates the pituitary to suppress the growth hormone. And therefore, we mentioned the insulin level will be low, the growth hormone level would also be low. It suppresses the IGF-1 and the IGF binding protein 3. But then it increases the bioavailability and action of IGF-2, which affects the muscles, the adipose tissue, and the liver to actually cause hypoglycemia. So the diagnosis of NICTH, of course, hypoglycemia that fulfills the Whipple's triad, low insulin, proinsulin, and C-peptide levels, because we mentioned the pancreatic insulin secretion is suppressed, low IGF-1 level as a result of a high IGF-2 that kind of suppresses the IGF-1 as well. Normal or high IGF-2 levels depending on the assay you're using. And sometimes some centers, we check the IGF-2 to IGF-1 ratio is expected to be high. And of course, the identification of a tumor. So the treatment of NICTH, of course, immediate correction of hypoglycemia, similar to our standard management. Definitive management is, of course, resection of the underlying tumor. But before surgery, or if some patients are not fit for surgery, you need to have some hypoglycemia-directed supportive treatment. For example, some evidence-based effective treatment includes high-dose steroids, glucagon infusion, but that can only be given in an inpatient setting, or recombinant growth hormone therapy. Or we try to increase the caloric intake by enteral or parenteral feeding or glucose infusion. So I think that ends our lecture for today. And if you have any questions, you could type in the chat box and I'll try to answer. Okay, so I don't see any burning questions right now. So maybe I just try to summarize the lecture today. A few slides that I think you need to bear in mind is that for hypoglycemic emergencies or diabetic emergencies, I think this is one of the important slides that you need to know. Be it is a DKA or you're treating a euglycemic DKA or you're treating a metformin-associated lactic acidosis, these goals of management always implies. So rehydration, or even when you're treating HHS, rehydration, insulin, correct electrolyte or plus or minus acid-base imbalance. Remember, there are a lot of precipitating causes like infections, ischemia, drugs, etc., and avoid complications of treatment. So I think for the first part, for DKA, glycemic DKA, HHS, lactic acidosis, etc., I think this is one of the important slides that you need to know. So in terms of hypoglycemia, do you know about the different causes of hypoglycemia in diabetic patients? And also some of the methods that can help you prevent hypoglycemia. For example, choosing newer technologies, choosing newer drugs or insulin analogs, education, etc. And do read about more about insulin action profiles, know about different insulins that we have. And finally, in non-diabetic hypoglycemia, know a little bit more about the causes. I don't think you need to know too much about these other drugs. And a general workup and how you interpret the results. So these are the few slides that I think would be most important in this lecture. So if we don't have any further burning questions, we could end the lecture today. And thank you very much.